Abdominal obesity is a common risk factor, but physicians may not have fully grasped its prognostic impact and its direct prevalence in patients with cardiovascular disease. During a special session organized by the International Chair on Cardiometabolic Risk at the Journée Européenne de Cardiologie in Paris, Gabriel Steg reported on the prevalence of abdominal obesity in the REACH registry.
The REACH registry is a large international registry on outpatients with established atherothrombosis or at high risk of atherothrombosis. And what was quite impressive to ourselves, the investigators in that registry, was the very high prevalence of obesity in that patient population with established disease. If we look at obesity defined as a BMI above 30, almost 30 to 40% of patients with established cardiovascular disease were technically obese. Now, if we look at it from a different angle and use an elevated waist circumference as a way to define obesity, maybe something that is more relevant to cardiovascular risk, and we used a simple and largely arbitrary cutoff of 100 centimeters for men and 88 centimeters for women, then we were impressed to notice that 45% of patients with established cardiovascular disease had abdominal obesity. This is extremely impressive because not only do almost half of our patients have increased obesity, or obesity technically, but this imparts a very substantial cardiometabolic risk. If we look at the population attributable risk, we know that roughly 20% of cardiovascular morbid mortality is attributable to obesity. So this is really likely to be a major factor in the future in preventing cardiovascular disease.
Jorge, after those comments we just heard about the REACH registry, do you agree with the comments of Dr. Steg?
Well, I think the REACH registry is very interesting, and it certainly provides support for what we know about the relationship between BMI, waist circumference, and cardiovascular risk. I suspect the REACH registry may even underestimate risk because it's an international registry, and we know that in certain populations, waist circumference may underestimate risk because of the use of different experience of what we see with, for example, Asian populations and waist circumference, and the fact that they can have visceral adiposity at even lower waist circumference than other populations.
So this is a definite message that cardiologists, physicians, within the context of cardiovascular disease, should always measure the waist circumference?
Well, you know, it's received a great deal of discussion, and I think in practice, at least in the States, many physicians, and especially many cardiologists, don't measure waist circumference. I think that that's because of controversy about, well, what are you going to do with that? But I would say, as someone who does use that in clinic, that it conveys a very powerful message to your patient when you measure their waist circumference, because they inevitably ask, because no one's ever done it, why are you doing that? And it stimulates an entire conversation with them that you feel that a great deal of their cardiovascular risk, or why they had bypass, why they had a stent, is related to their adiposity in their abdomen, and that you would like to see them not return to ideal body weight, but to just achieve the first 5 or 10 pounds and have a little bit of an improvement in their waist circumference, because so many parameters get better with that.
Some years ago, we measured in Belgium the waist circumference together with age and some risk factors in a large group of diabetics. And there it clearly came out that the target that was reached for lipids, for blood pressure, and for cutoffs of waist was only reached in 5 to 6% of that population. Also in the REACH registry, there is a paper on how the targets are reached. Was that good, or was that not appropriate?
They just had a paper came out in November looking at individuals who had undergone coronary bypass in the REACH registry. And it documents very well that even in patients who undergone bypass, so we know they have the disease, we know that they've already undergone a major intervention for coronary atherosclerosis, that is a relatively few percentage of them are getting control of the major drivers of cardiovascular risk, and interesting major drivers of maintenance of the bypass grafts.
So I think that not only for diabetes, for many other risk situations, but definitely for patients with coronary heart disease, patients who underwent a coronary bypass grafting, that they should be stimulated to control their weight and more specifically the accumulation of abdominal fat. And just an easy measure of the waist circumference is a very easy tool to control that.